appreciate the Black Women's Blueprint for allowing me to be here this morning and really just hold this very intentional space. Yeah, and I appreciate the grounding that you led, because I think that especially when we're in community, we need to recognize each other and understand and hold each other, especially for this very intentional conversation. I'm not a mic person, so this is going to take some time. I usually speak loud, but it is the morning, so I'll hold the mic for now. So this morning, I'd like to talk a little bit about the intersections of violence, but more specifically, our gender-based and systemic violence and oppression, my journey that led me to reproductive justice, and then lastly, my personal pregnancy and birthing story. We know that gender-based violence shows up in a number of ways, such as deprivation of resources, information services, coercion, sexual, verbal, physical, emotional, and psychological abuse, weathering on our bodies, and erasure, and is especially present when inequitable power systems and dynamics are at play. For instance, I mentioned erasure. I'll tell you what I mean, a little bit more about what I mean by that. Our erasure of people's identities by continuing to conform and function under explicitly gendered binary society and systems, in effect erasing whole people and their experiences, eliminating their bodies from healthcare systems and practices, eliminating them from policies, and in a sense, trying to erase them from society. Standing up for trans and gender non-binary, intersex, agender, and queer people truly means being there. Walking them to their cars, giving them rides, going to the store with them, checking in with them to assure they have the things they need to feel safe in their community. Assuring that our policies, services, and resources are inclusive of all of our bodies. For instance, we know that not all people with a uterus identify as being a woman, right? You know that? And many need gynecological services, right? So what do we do, and what does that experience look like when a trans man needs a PAP or an abortion, or would like to preserve his eggs for fertilization? And how does the healthcare system treat trans women who want to preserve her sperm? These topics are not widely discussed, and because they are not discussed, in effect, they are left out of conversations around maternal health, reproductive rights, and health. This is reproductive violence and oppression. My organization, Spark Reproductive Justice Now, right down the street, just a little shout out Spark. We define reproductive violence and oppression as systems of oppression, institutional and social control, eugenics, medicalization, violence working to uphold negative policies, practices, and cultures. Let me give you just some everyday examples of the ways in which reproductive violence and oppression shows up. Criminalization of sex and sex work. Criminalization of migrant families and the caging of children. Restricted, limited, and or no data or research on queer and trans young people of color, and no data and research led by queer and trans people of color. Research and data limited to cis-het folks. Everybody know what cisgender, heterosexual, heteronormative. And then if there are terms after this that in the Q&A, we can break that down too as well. Population control policies, either subtle or covert. Lack of access to reproductive and sexual information and education. Coercing use of contraceptives on marginalized groups. Forced sterilization. Family caps on welfare policies. State and federal policies against abortion. I mean, I can continue to go on, but I only have 40 minutes up here. I got a lot more to say. Reproductive justice exists because of reproductive oppression, because of the violence that affects our ability to live equitable, healthy, and holistic lives. Reproductive justice is about dismantling controls and systems that act as barriers to equity, bodily autonomy, and self-determination. It is about ending the policing of our bodies, shifting the narrative on reproductive justice to uplift pro-sex, pro-safe sex, sexuality, gender and queer bodies, access to abortion and contraceptives, birth rights and chosen families. This allows us to begin to think about the many ways of the issues that come at the intersections between reproductive health rights and oppression. Okay, so previously I spoke about coercion, I just mentioned it, as a form of violence. So I'll tell you a little story. Now that we're in Georgia. So yes. As I said before, I came from California, no way of LA. So I'm gonna Shaw to be exact, but I've got a whole other story later on if you want, offline in the parking lot. So I came to Georgia, and no, let me start here. Before I came to Georgia, I know my little bio said I worked in system of narcotic treatment programs, but truly, my direct health career has been working with marginalized communities that were displaced as far as housing, homelessness, experienced intimate partner violence or some violence of some sort, mental health, and as a result, went into substance abuse, specifically opiates. So as I navigated kind of through my lifestyle, my career, so to speak, or what have you, I remember wanting to come to Georgia one summer to have fun. Like, I was like, all right, I'm in my mid-20s, I'm out of school. Let me come to Georgia because, it's Georgia. Like, I just wanted to have a good weekend. And I remember landing and being somewhere downtown. We're actually situated downtown. So I remember being in downtown and looking around and thinking, wow, so many people look like me. Like, so many people, and of course, California, they call it a melting pot, but I've never been in a space where I found so many black people and brown people and just felt like, wow. And then also in looking around, so many displaced people. I'm right downtown, so many people that I'm looking around are sleeping on the floor, homeless. I started walking around and talking to people, just who I am, and also like public health. You need to learn your community. So I'm, hey, how you doing? Do you need anything? And predominantly what I found that people were displaced, did not have access to health insurance, did not know their HIV status. One person didn't even know if they were pregnant. They were like, I don't know, I'll figure it out. But also did not want to know their status as such because out of fear of not being able to access treatment for care services and not knowing what to do with that information and having to live an isolated kind of life and the shame and guilt that comes with that, etc. So I was like, this is a community I need to be a part of. Like, I cannot be this public health person and really be situated in a space that my community is not thriving in. And so in 6 months I moved down to Georgia by myself. I don't know what I was doing, but by myself and by way of the Department of Public Health. Now, interesting enough, where I was situated, I learned that the Department of Public Health was right across the street. And the fact that the pivoting of the images of like who we are and how systems come to play and how do we directly connect with our community to really center on equitable access, like really hit me. And I didn't know that until my first day at work. I was like, oh shit, like I was right here. So I remember working at the Department of Public Health, and this story is about coach. I was with DPH, and we're kind of going through a reorg, and I had some folks in the room that was there when I was there, so they know what I mean by that. And this is at the time when DPH was not awarded with the Title X funding, so a deficit of about $16 million. And it was like, all right, girl from California, I need you to kind of help us, our executive leadership team, redesign like what these services are gonna look like and oversee kind of our family planning stuff for the state of Georgia. First week on the job, so I was like, all right, well, shit. So I'm gonna let's do this. Like, I was really excited. Let's do this, and they're like, no, actually, this is what we've always been doing. Things are not gonna change anything. But anyways, that's neither here nor there. So I set out on a mission to visit our public health centers in Georgia. Now, Georgia has 159 counties, approximately at the time 192 different public health centers, right? So I wanted to know what, I'm coming from direct care services. So I wanted to know what our communities look like, what our patients needed, what our intake forms look like. I needed to know what it felt like to be a patient here in Georgia. So I went to about 30 clinics in a 3-month period. And I remember, and everywhere, in places I didn't even know existed, and which is true. So, deserted, like food desert kind of landlocked spaces. And I remember at some facilities I stayed silent, I just sat in the waiting room. I just wanted to know what people were talking about, what they looked like, what their experiences was. Some folks I asked if I could speak to them. I spoke to the staff, I looked at the paper, very binary, I'm just gonna say, male, female, that's it. We can deliver services, which is a whole other speech. And then so I remember at that experience, I wanted to know what it felt like from the time a patient checked in and the time they checked out and everything in between. And in my conversations with our patients, I asked, well, what are your top three primary methods of contraceptive that you would prefer? First, barrier method, your condoms and such. Secondly, they said, I prefer a rhythmic method. I prefer to have control over my own body. Some was like pull out method, some was just like I know my body. And lastly, it was birth control pills, primarily birth control pills. So I went back to that information, worked with our epi team, and looked at the data, and we were like, okay, perfect. The information I received actually correlated with the data. Go back to our team, I'm like, this is what we need. We need to pour, because our task was to modify services and roll out the ones and put money into the ones that we truly needed. Needless to say, all the money went into Lawrence. So complete disconnection to what people said they needed and desired in community and what resources were put directly into. That's a form of coercion, and that's a form of reproductive oppression. And that story is not to pivot on a specific system or organization because, organizations and systems do provide services for our community. That story specifically is to really truly get to the root causes of what's going on systemically so we can address these issues. If we do not have very transparent, clear conversations and we're scared to talk about what's going on systemically, this shit's always gonna go on. We're always gonna have systemic oppression and systemic violence that continues to perpetuate on our communities, specifically Black and brown communities. Next story. No, I'm just kidding. But no, honestly. So those are the reasons that actually led me into reproductive justice. I feel that with the healthcare system and with the our political and governmental systems interconnected, we need people in all sectors. We need attorneys, we need doctors, we need researchers, we need public health folks, we need teachers, we need scientists. All of us that make up our community to work together to truly discuss the ways in which we can dismantle these systems of oppression. Okay, so earlier I spoke a little bit about deprivation of services and resources about as a way of reproductive oppression and violence. Okay, so one example of this is the abortion bans here in Georgia. Okay, so let's talk about it because we're right here in the South, we're right here in Georgia, and we know that these bans are affecting a number of different states, but specifically within the Southeast. So the abortion ban is ideally a healthcare ban, point blank simple. It is a forced pregnancy policy that denies a person their right to self-determination and bodily autonomy. This is a critical public health issue, and if not stopped, will be a dangerous public health crisis for the state and many other states. Georgia already has, I know you guys know, but just in case, the worst maternal child health outcomes in our nation, okay? The worst maternal health outcomes related to morbidity and mortality rates in our nation. And this is comparable to other underdeveloped countries. Put simply, when people lack access to safe abortion services, they die. Okay? Lack of access and now restriction of access will not result in people not having abortions. This will only result in an increased amount of unsafe abortions. This is a critical health issue specifically for Black, brown, indigenous, trans, queer, non-binary folks who already have severe limitations to access of affordable and affirming reproductive and sexual health services and healthcare coverage. Black people who are living under federal poverty level here in Georgia are less likely to be insured and therefore are less likely to be aware of pre-existing medical conditions that they may have, such as high blood pressure, hypertension, cardiovascular disease and issues. So if you were to become pregnant and you are now uninsured, then ideally you would be forced into a high-risk pregnancy. Not to mention the weathering on our bodies, but I'm going to speak about that a little bit. Moreover, legal abortion is safer than continuing a pregnancy to term and having an abdominal cesarean delivery. I'll repeat that. It is safer for me to have an abortion than it is for me to deliver via cesarean here in Georgia. Let that resonate a little bit. Deprivation of resources and services as a form of violence is directly related to our poor maternal health outcomes in Black communities. The historical and current systemic violence against Black people has weathered on our bodies and is causing us to die. Additionally, systems that are built off of racism, sexism, and discrimination is directly linked to our lack of access to quality care and comprehensive maternal health services. Black people in the U.S. experience unacceptable poor maternal health outcomes, including disproportionately high rates of death related to pregnancy or childbirth. Let me give you more facts to connect the dots, but I'll also mention that most research is centered on cishet Black women, so just understand kind of the variables in that. So one, due to racism and sexism and other systemic barriers that have contributed to income inequity, Black cis women are typically paid just 63 cents for every dollar paid to white non-Hispanic men. Median wages for Black cis women in the U.S. are a little over $36,000 per year, which a little over $21,000 less than the median wage for white non-Hispanic men. These lost wages mean Black people and their families have less money to support themselves and their families, and may have to choose between essential resources like housing and childcare, food, and healthcare. These trade-offs are evident in Black maternal health outcomes. Compared to white women, Black people are more likely to be uninsured and underinsured, face greater financial barriers to care when they need it, and are less likely to accept prenatal care. Black people experience higher rates of many preventable diseases and chronic health issues, some that I mentioned before, diabetes, hypertension, cardiovascular issues. When or if Black people choose to become pregnant, these health conditions influence both maternal and infant health outcomes. Maternal and infant health outcomes, so I'm going to differentiate that, okay? Black women are 3 to 4 times more likely to experience a pregnancy-related death than white women. Black women are 3 times more likely to have fibroids, so benign tumors that grow in your uterus and cause postpartum hemorrhaging, than white women. And the fibroids occur at a younger age and more quickly for Black women. Black women display signs of preeclampsia early in pregnancy than white women. This condition, which causes high blood pressure during pregnancy and can lead to severe complications, including death. And Black women experience physical weathering, meaning weathering on their bodies, and their bodies age faster than white women due to exposure to chronic stress linked to socioeconomic disadvantages, and discrimination of the life course, thus making pregnancy riskier at a younger age. The weathering on our bodies, okay, that makes our lifespan shorter, that makes our bodies age faster. I know we like to say like, oh, our melanin's popping, like, you know, we're 50 years old and we look like we're 12. That's true. It's definitely true, and also the weathering on our bodies internally as far as our health outcomes, okay? Again, you know, I can go on and on. There's an infinite amount of data that shows just our poor healthcare outcomes, but I think we get the point here. Lastly, if you can recall, I mentioned weathering as systemic oppression and as a form of violence. So the last story I'm going to tell you today is about my pregnancy and birth story. So, this might be a little touchy. So, about 2.5 years ago, I became pregnant, and I decided to keep my child, right? To keep to carry my pregnancy, actually. And that was a decision that I made. And then I delivered my kid early. Name is Amir. So Amir was born at 27 weeks, was 1 pound 12 ounces. Let's see, he stayed in the NICU for 121 days, so roughly about 4 months. And he's really good now, so cute. He gets on there since 2, so that's why he's not here. But no, so yeah, he was born really early, stayed in the NICU, experienced pretty much every health challenge you can think of, went through a multitude of different surgeries, was on oxygen, and had a brain hemorrhage, and had a shunt, and had cerebral palsy, and just a lot of different health challenges. And research shows, data shows that if you have a higher socioeconomic status, you are more prone to better health outcomes and less at risk for poor maternal health outcomes and infant mortality or morbidity rates. And I think I'm kind of smart. I've been up here saying some good words, so I only got a few degrees, but I think I'm smart. I make a good living. I have health care insurance that's not limited, that I'm able to pay for, and that was not my story. And it wasn't my story just because it wasn't just like the roll of dice and I just became one person that had that experience. No, it's because the weathering that was placed on my body, and specifically because I'm Black, and I'm Black living here in the South. And yeah, so I wanted to kind of center on that a little bit, but also going into a little bit more into that story, the ways in which systemic oppression and discrimination kind of shows up in these spaces. So about a week after Amir was born, he was born at Northside Hospital, so in North here, and right across the street there's Scottish Rite Children's Hospital in Atlanta. So a week later he was transferred across the street for emergency surgery. And I remember we got a call, that's my partner in the back taking pictures, so. We get a call at 3 o'clock in the morning saying, your kid needs emergency surgery, or, he's not gonna make it. I got preeclampsia, so I was literally on my deathbed delivering. So, there's a week after me delivering and trying to heal via cesarean, and just getting home and told, like, let's get to this hospital. So I can't even walk. I don't even know how I got to the level with his floor. Like, I don't know what happened, but I got there. And I remember being in the NICU, people don't have their own rooms, it's pods of beds, incubators, right? So I remember we walk in and there's probably about 15-ish people around this small incubator. And so you have your transport team, your respiratory team, you have, your NICU nurses, your NICU admission doctors, you have your surgical team, all these folks around, doing their intake of this patient, and around. So we walk in, and clearly we're the parents, and no one greets us. My kid's surrounded by all these professionals, no one says anything. We find a seat, I sit down, I sit down. Still, no one greets us. I'm, wondering, I'm not wondering what's going on with my kid because I know what's going on with my kid, but I'm just wondering when the hell is somebody gonna turn around and understand that I'm a part of this treatment team, but okay. So then, at some point, our surgeon, this young Black woman, comes over to me and says, before I speak at you, can you tell me what you believe is going on? I said, well, thank you. And in that instant, I remember literally a snap in my head that literally said, all right, put away parent and activate Dr. Redman. And I went into spitting out his entire treatment plan report, the time he was transported, what was going on, what his diagnosis was, what was the care of action, et cetera, who was admitting him, who was on the team, et cetera, et cetera, et cetera. Giving all the stats, how much he weighed, everything. And I remember after I finished that, everyone who were not people of color turned around and said, huh. 3 people came over and said, what do you do? Like, what do you do for a living? What do you do? Oh my gosh. Another person came over, would you like some tea or coffee? Excuse me, Dad, would you like a seat too? We got these chairs that recline. Remember those chairs? we didn't have the little pull-up chairs anymore. They gave us the ones with the cushions. And I remember thinking, what the fuck? So I have to ideally show up in this space to show you how Black I am in order to get the treatment and humanity my child needs, and I need as a parent to be included in this treatment team. So, let me go back to my notes because I don't want to start cussing and stuff. So let me just let that breathe in. It should be enough for me to show up in these spaces, in a healthcare space, and be there because I need the services or the people I love in these services. I should not have to show up as Dr. Redman or legislator such and such or attorney such and such or whomever. I should not have to show up in those spaces wearing my title or ideally showing how Black I am to these systems in order to get the care and the services that I need or my kid needs. Again, this is systemic oppression, this is violence. Whew. I was filling out one, so I got lost, so even in that, I remember thinking, we need to tell our stories. These stories exist more often than you think with people in our communities, but we do not tell our stories. So like a little shameless plug, I wrote a book, you know, said in my intro, I'm a miracle. My kid's name's Amir, so I am a miracle, and I was born Earth. And it really aims to normalize these conversations specifically in Black communities. So on the cover of the page, I could have put a picture of Amir after he was completely well, and it's an animated book, it's like a children's book, and it's narrated through Amir's eyes. But I chose to put a picture of a young Black kid with his NG tube, with his nasal cannula, so oxygen tube, his feeding tube, everything, he's just smiling. Because we need to have these conversations of what our children here in the South, as well as in our nation and Black communities look like, and what those birthing stories truly look like and feel like. But you know, like I said, shameless plug, but in all seriousness, it is important to normalize these type of conversations. So in closing, my birth outcomes were worse just because of the multiple identities that I carry, and also my geographic location being here in the South. The breeding ground of racism and oppression. I love the South. I mean, you would have known that if the music was like really playing, like, but I couldn't really dance to that. You couldn't really dance. That would have been weird. But I do love the South, and I also know that it is deeply rooted in racism, that is intertwined in every system and in the people that has weathered on my body and the bodies of those I share community with. Weathering illuminates the impact of racism as a more pervasive form of stress, requiring a more complicated understanding of the ways in which systems of oppression impact our health and our lives. Weathering stems from a complex web of social and cultural relations and anxieties that influence stress levels, a consequence of the lived experience of Black people in America. Further, it is important to note how violence shows up in systems that has historically been treated against or created against Black and brown people. When we eliminate choices, remove and limit services and care, and more so, target communities, that is systemic oppression and violence. When we coerce people into services who are saying they clearly do not want, these are ways that systemic oppression shows up. The history of forced sterilization and our modern day forms of sterilization and coercion, and how eugenics and population control are intrinsically embedded in our political and healthcare systems, shows that quality healthcare systems and coverage were not created for marginalized communities. If this was the case, Georgia would have expanded Medicaid, or even better, the US would have comprehensive free universal care. Systemic violence is the fact that Black, brown, and indigenous people are denied the ability to care for their bodies, families, and communities, and often criminalized for daring to do so. Denied the right to be treated with humanity in spaces where they are trying to access resources in. Hence the ways we are forced to show up in those spaces by proving how un-Black or brown we are in order to be treated as whole people. It's how queer and trans people of color are used to fill diversity quotas such as aesthetics and entertainment and labor, but erased from every conversation about their health and their families and their futures. Reproductive justice is creating and dismantling spaces where Black and brown folks, queer and trans folks are seen as whole people. Where we all have the access to affirming resources to create our futures and tell our stories, where we are seen, respected, and celebrated. When we operate off the premise that the intersections of gender and race-based violence start and stop as cishet Black and brown people, this is not reproductive justice. In fact, sexual violence and systemic-based violence increases and intensifies even more for people navigating multiple and marginalized identities. So being Black and brown and trans and queer and younger and older and disabled, etc., multiplies. When we erase people, when we eliminate and limit services and coverage, when we continue to allow systems to exist that thrive off of racism and gender-based violence, this directly affects our health, including maternal morbidity and mortality, directly affects our bodies, our families, and our lives. This is not justice. In fact, this is a reproductive justice issue, which are and will always be linked together.